you doing?
Oh, look, Catherine's getting wellness, the nervous system.
Hey, that's you.
His legs are so
Oh,
Yeah.
Less.
So we are here with Dr. Slak today. Welcome. Thank you so much for taking the time out of your day to talk
It's
to
my
us.
pleasure to be with you today.
So I just want to start with, you have been in the field of chiropractic for over 40 years now. So I just want to turn the dial back to when you first started, and could you just talk about what experiences led you to chiropractic and specifically to pediatrics and ties in the end?
So what led me to chiropractic was I had a cousin who was in a very bad car accident. He was driving a brand new car down the highway and a wheel fell off. So he had, from that, the repercussion was that he had a blown disc in his back. And he had a friend who was a chiropractic patient and said, please come to see my chiropractor before you go for that orthopedic surgery that was recommended. And he went to see the chiropractor, and the chiropractor said, I think we should do a course of care before you consider surgery. And his problem resolved, and he never needed the surgery. So that's how I was first introduced. I was a junior in college. I had no issues, but was told, hey, why don't you just go check it out? So I went to the chiropractor, and actually it's probably a chiropractor's dream to have someone come into the office and say they're here for wellness. They don't have any aches or pains.
Mm-hmm.
So that was the beginning of my journey. And then in the beginning of practice, we've always had a family practice here in Burlington. And about 20 years ago, I decided that I wanted to specialize in pediatrics. Reason being is I had a daughter who had special needs.
Mm-hmm.
She has dyslexia and a specific learning disorder, and watching her brain fascinated me because it's so different than anyone else in the family. And there set off my curiosity and studies to become a pediatric specialist. So first I studied with the International Chiropractic Pediatric Association, became certified in pediatrics, and later on became an instructor for that organization. And then I went on to study neurology because the brain just fascinated me even more. And I studied with the Carrick Institute and became certified in child neurodevelopmental disorders.
Wow, it's a very impressive journey, yeah. So could you just talk a little bit about what are the differences between mainstream medicine and chiropractic care in terms of what you focus on, what your goals are?
Yeah, so chiropractors deal with or focus on the central nervous system. So as we know, the nervous system controls everything in the human body. If we were to look at the spine, we can see that the brain, for example, is the only system or the only organ in the body that's totally encased in bone. It's very, very important. So the brain then sends signals down through the spinal cord and out through all these nerves at every level of the spine to supply and function every single organ in the human body. If there's any interference to this system or to any area or to any of the nerves, it's going to decrease the functioning of that organ, system, tissue, cell. So as chiropractors, our job is to make sure that this nervous system is free of interference so that the body can function optimally.
Mm-hmm.
Whereas modern medicine is dealing with more than function. They're looking at, right, you go there when you have a problem. And oftentimes people will come to us when they have a problem too. Like if people say, hey, I haven't been to a chiropractor before because I don't have neck pain or back pain or low back pain. But as I said previously, when I started chiropractic care, I had none of that.
Yeah. All right. So just to hone in more on pediatrics, why are infants referred to you, and how does chiropractic help with the problems that you commonly see?
Well, first of all, let's talk about where my practice is today. Today, my practice is about 90% infants. It just evolved that way because about 10 years ago, the other Dr. Slak, my husband, who I practice with, he said, your knowledge is so far above mine now, why don't you see all the babies and the children? So that's how my practice evolved that way. And then this thing called tethered oral tissues came into our view, and we started seeing more and more infants having problems with feeding, difficulties with latching, and referrals came from IBCLCs, the International Board Certified Lactation Consultants, who would see the infant and notice that there were tensions in their body and that they weren't functioning properly, there was dysregulation, and they would send them to us for care.
Mm-hmm. So a lot of worries that parents have when coming to chiropractors for their children is that they're not sure if their treatment for their child is going to be as aggressive as shown on like social media, like they're pulling limbs, breaking bones, all of that, which I'm sure is not actually true. So could you just talk more about how treatment for infants differ from adults?
Absolutely, it's completely different, and I get this all the time from all other providers where parents are afraid because they think that we're going to do the same thing or experience the same thing that they experience when they see the chiropractor. So pediatric chiropractic is a specialty, and you want to look for somebody who's certified in pediatrics before you take your child to them. And it's very gentle, very safe, very effective. As a matter of fact, with infants, it's just about the amount of pressure you would use to test the ripeness of a tomato or an avocado. So it looks like nothing. Sometimes parents will say, it doesn't look like you did anything, but that's all it takes. It's very gentle. There's no twisting, there's no cracking, there's no noise.
Yeah.
So this is just a rapid fire Q&A. We're gonna do 5 sets of 3 concepts each, just connect them in a few sentences, talk about the connections between them. The first 3 is breath, tongue, and palate.
All right, so when we're looking at the coordination of suck, swallow, and breathe, it's affected by where the tongue's resting in the mouth. So in resting stature of the tongue, it should be lifting and resting on the roof of the mouth, whether you're at sleep or at rest or awake. And if it's not doing that, then there's going to be difficulties, or it's going to disrupt the ability to suck, swallow, and breathe. So we have it with tongue ties, we often see a palate that is high. And what that looks like in an infant, if the palate is high, it's going to create a space, and they're not going to be able to rest their tongue onto the roof of the mouth. So not only once the tongue tie is released, we need to address the palate as well. Sometimes we can do that with cranial work, and other times we need to make sure, or maybe it'll be addressed later on with palate expansion and orthodontics.
All right. So regarding to tethered oral tissue, what is like the prevalence in infants, and when does it occur in fetal development? Like when does it start to form?
Sure. So the tethered oral tissues, if you look textbook, it's about, the latest research shows that it's about 10.4% of the population. But if you were to spend a week in this office, you would think that it was 90% of the population. I remember being at speaking for the Mass Coalition of Breastfeeding about 6-7 years ago, and one of the dental providers was there, and he said in New England it was about 50% of the population of babies in New England.
Oh, wow.
At that time, I started lecturing all over the country and all over the world, and I remember a talk in 2016 in Chicago where there were about 80 doctors in the room, and I asked them, who has heard of tethered oral tissues, and not one hand went up. So that was only 2015, 2016, and not so long ago, right? In 8 years, it's known all over the world now and very prevalent. So really, really grew, and it cannot be totally a genetic thing because it's grown so rapidly from the years. And what was your second question?
When does it develop during fetal development?
Yes, so in fetal development at around 14 to 16 weeks of gestational age, the infant frenulum underneath the tongue undergoes what we call apoptosis. The frenulum thins out and retracts. And what's important about that is at that time, it then allows the tongue to lift and raise and rest on the palate, which helps to shape and form the palate in a normal form from that point on. So when the tongue is tethered and down and can't lift properly, that is going to affect a few weeks later when suck and swallow begins. When suck and swallow begins, the tongue, if it's tethered, isn't going to be able to perform that rhythmic motion appropriately, and the fetus is going to be compensating for suck and swallow from that stage on. So that's why when then the fetus is grown and born into this world, they have feeding difficulties, and the parents don't realize often that it started way back when in fetal development.
Yeah, so would you say the best time to sort of assess and diagnose and like kind of work to fix this problem would be during infancy? Like what are the impacts of just going and kind of ignoring the problem and just going through your life and growing up? Like what are the impacts it can have?
Yeah, so the impacts are varied and unknown, really. Every person, every baby is different. I've seen adults have tongue tie releases because they realize that they have had tensions in their bodies for years and years and years, and the tongue tie was contributing to that. But when a tie is detected in an infant, I think the earlier that it's released, the better, because with it remaining there, the tongue is part of the fascial system. So the tongue you can think of that as like spider webbing that goes from head to toe. And if it's tense and tight and tethered, then it's going to create tensions throughout the whole entire body. So therefore, compensatory strains throughout life that are unnecessary if it's released early.
Yeah.
It's not going to happen.
Yeah. So could you talk a little bit about how you classify, like are there different types of tongue ties, and do they vary from just like how bad they end up being, like the impact that they have?
Yeah. So we'll go with the classification from the tip of the tongue, calling that class 1, and that's when the frenulum is very thin and connected to the tip of the tongue, and you'll often see or hear about a heart-shaped appearance of the tongue. And then the next stage 2, class 2, is when about 3 millimeters back, when it attaches from the tip of the tongue to the alveolar ridge, and that would be a class 2 tongue tie. Class 3 would be past the midline of the tongue, further back, and as the tongue tie goes further back, the frenulum is thicker, shorter, more taut. And then the 4th phase is way deep back where it connects to the floor of the mouth.
Okay, yeah. So now an infant has been like accurately diagnosed and assessed for a tie that is affecting the functionality of their mouth. I just want to talk a little bit about the next step, which I believe is a release, right? So could you just talk a little bit more about what a release is and what does it entail as a procedure? So
infants usually report, or the parents report, that they usually have difficulties most of the time right from the start. So it happens in the hospital when the mom is trying to breastfeed from the beginning, and the lactation consultants there will address or look in and let the mom know that there's a possible tongue tie here. After that, though, the parents usually seek out the advice of a lactation specialist, and they go to see the lactation specialist, and there's usually other things going on with the tie. I call the tie sometimes the tip of the iceberg. It could be all that's going on, but many times and often we'll see babies with lots of tension. Their shoulders up to their ears, or the parent will report, oh, my baby's like advanced. They can already, a newborn, roll to their side. They already can lift their head in tummy time, or when they're on the parent's shoulder, they have good head control. That actually is a sign of tension, not talent.
Yeah.
So when the infants like that, the lactation consultants know that that's a sign of tension, and they will refer to the chiropractor, because the importance of that. So that's the next step. Infant comes to the chiropractor, we do a complete, very thorough exam. We're looking for ranges of motion, we're looking for any torticollis, which means the head's tilted and rotated. We're looking for symmetry of tone. Is there hypertonicity, meaning the baby's really tense and rolling to their side, or is there low tone, where you can raise their leg and raise it right above their head, which is abnormal. So we're looking for all their deep tendon reflexes and their primitive reflexes to make sure that they're activated. And then as a chiropractor, the most important thing we're looking for is evidence of where we see that nerve interference, because those nerves that go out and to control all the muscles of mastication, including the tongue, we need to make sure that there's no interference. Okay, which happens most of the time at birth. No matter how the birthing process occurred, there's usually pressure on the nervous system. There's actually studies on that show about 99% of infants born have some form of nerve interference in the upper part of their neck, at the base of the skull.
Yeah, 3, 2, 1, go.
Next 3 words are nervous system, fascia, and ties.
All right, as we know, and it's already been said, the nervous system controls and coordinates everything. So if you release ties or you're not going to get proper tongue function unless the nervous system is functioning well. That's the role of the chiropractor. And then we have the nervous system fascia. The fascia is that system sitting underneath the skin. It's like spider webbing that connects everything all together. The tongue, the frenulum, is part of that fascial system. So if it's tight or if it's tethered, it's going to affect the fascia everywhere and create tightness and tensions within the body. And once it's released, it will release all of those tensions. That's why we see like hypertonicity in an infant they'll become more relaxed and their tone will normalize. Or in an adult, they might have chronic pain somewhere or neck tension or even down to the knee that will release when the tongue's released.
Yes.
So
is that like a trend you've been seeing, or has it been increasing, or has it always been present?
It's always been present, but more today.
Mm-hmm.
So years ago, that's a very good question, because years ago when I first started practice, I didn't see babies with tongue ties or many issues. Parents would just bring them in when they were on their way home from the hospital for a checkup. We would see them and say, see you in a month. But today our babies are being born with all these many more tensions in their bodies, many more difficulties latching. In my day, I never saw babies with latching issues either. So it's really escalated. I can't tell you why.
Oh, okay. That's going to be my next question.
Yeah. So next step. So we do our thorough exam, get our history together based on the history and the age of the infant. We then create a care plan. So the care plan is going to consist of some visits before the release. The purpose of that is we want to normalize tone and symmetry as best we can before the provider goes in to do that release. Now, if it's a dental provider, we always get feedback from them saying, wow, that was so good that they were able to get a deeper release, a better release, less chance of reattachment because of the body work that was done, releasing all that stress off of the system to begin with. Okay, so it's preparation. And then following the release, what happens is, now remember I talked about the frenulum being part of the fascial system. So imagine that you now have cut through the frenulum and you've released the fascia. So you've gone from tension to so one of the things that I hear from adults, because babies can't talk, is that, wow, I felt like my shoulders dropped to 5 inches, 10 inches, and they felt much more relaxed throughout their whole body. I even had one mom who had knee pain that went instantly away.
Oh, wow.
So you just never know the effects. But after that release, the brain doesn't know that tongue was released, right? Just like if you had lost a limb, you still have a phantom limb.
Yeah.
So the brain is still giving improper signal to the tongue. So as it's healing, we need to keep the pressure off the nervous system, and that fascia, we need to make sure that in the healing phase, which is about 6 weeks post, that we don't form any compensatory strains anywhere else in the infant's body. So we do craniosacral therapy, we do cranial work for the cranium itself to make sure that the cerebrospinal fluid's flowing properly and well, feeding the nervous system well as well. So there's really 3 components. It's the chiropractic adjustment, it's cranial work, and it's craniosacral therapy.
Could you talk a little bit more about craniosacral therapy and maybe other modalities that you also use to help along with at chiropractic care when a child has a tethered tissue?
So the craniosacral therapy is, like I said before, it is working directly with the fascia and the layers of the tissue to take the tensions out. So when we do the craniosacral therapy, I'll tell the parent that, your babe, don't be alarmed if your infant no longer rolls to their side, they're resting on their back, or that they're happy to be on their back, or they're happy in tummy time. The purpose of that is it releases all the tensions and balances the fascia throughout the body.
Okay, so to talk more about fascia, can you talk about how, like, first explain what the fascia is for people who may not know, and then also explain how it connects, like, the whole body together and how it connects to ties.
So the fascia is that layer of tissue that sits right underneath the skin.
Mhm.
It looks like, you can think of it as spider webbing, and it intertwines through all the organ systems all the way from head to toe.
Mhm.
The frenulum is part of that fascial system, as I said before. So it's all connected. When there's tension somewhere in the fascia, it's going to there's going to be compensations, there's going to be effects throughout the system. And if you think of when we're looking at a baby, they're small and tiny, right?
Yeah.
So less area, and they're going to have more tensions. You're going to see it. You're going to see it more and notice it more. Also, like in toddlers, you may even see that they toe walk, or that they extend their feet like this, because you actually can sometimes see the tension all the way down to their toes.
Oh wow. Oh, that's really and fascinating to know. Just like you said before, the tip of the iceberg. So there's a lot more going on underneath.
Yeah.
Yeah. So can you talk about, going back to the cranium, can you talk about how the cranium plays a role in this overall?
Yeah. So if we look at the palate, and we oftentimes, because that tongue got tethered down, remember we were talking about the palate and the formation of it, that palate the infant will be born with a high palate, a bubble palate, sometimes we call it high bubble palate, narrow palate, and when that happens, that creates a huge space. So even after the release, when the infant's trying to suckle, they have this big space here, so they're going to draw in more air, which might cause gassiness, right? It might cause clicking. And so in cranial work, we're dealing with, all the bones are connected to one another. There is one bone called the sphenoid bone right in here, goes across the skull, that connects to almost all the other bones of the skull, but the palate, the maxilla, is part of that system. So when we're working with that cranial system, we can work to relax and improve the shape of the palate, as well as after the release, the baby's tongue is going to be lifting up and resting there, hopefully, in sleep. And their mouth is going to be closed, and they're going to be breathing through their nose. So that palate can potentially have some help to reform or spread out, and not need, or maybe the baby won't need a palate expander when they get older.
The next 3 words are ties, nursing, and breathing.
Great. So infants who have ties have difficulty with the suck, swallow, breathe mechanism. And that, because they can't suck, swallow, and breathe and coordinate that, they have difficulties with nursing, or feeding from a bottle for that matter. So with that difficulty, they're going to become frustrated. They're going to be pulling off and on the breast. They're going to be screaming. It's going to create upset with the parent who's feeding them as well. And so then all that stress creates and puts the baby into sympathetic dysfunction, or what I call sympathetic overdrive. Once they're in that sympathetic overdrive and they're distressed, their nervous system is so stressed that it just causes the problem to get worse and worse and worse. So until those issues are addressed, and until we relieve the cause of what's causing the issues with suck, swallow, breathe, which is partially by doing the tongue tie release, we're not going to see good function with the infant. It's also going to affect them with their neurodevelopment in the future as well, if it's uncorrected, because when they're in stress and they're under so much stress and they can't coordinate suck, swallow, and breathe, it's going to affect their ability to potentially meet their milestones through the first year of life.
So is that what craniosacral therapy is used for? Because you also talk about how that's different from chiropractic care. Yeah,
so craniosacral therapy deals mostly with the cerebrospinal fluid and the fascia. Cranial work is dealing directly with the skull, with the bones of the skull, making sure that they're aligned. And if there's any pressure in the skull, you can see how it could create tensions within, or it'll impede the flow of cerebrospinal fluid, and then the nervous system from there down isn't getting bathed appropriately. It's not getting nourished.
Mm-hmm. Yeah. So now I'd like to focus a little bit about the collaboration aspect of just caring for infants. Can you talk a little bit about what other providers should should professionals coordinate it with for the best outcome for infants with oral issues?
So this is really important because when, in my experience, when we have the correct team, we get the best outcomes. So as I said before, the IBCLC refers to me. I then do some pre-work, send them back to the IBCLC to get approvals or agreement that the infant or child's ready for the release. Then off to the dentist they go. The dentist does the release, gives them special instructions for stretching or exercises, and then they return for their aftercare here, and also they need to follow up with the lactation consultant as well for the latching part, because we don't do that, right? So the whole goal here is to have a successful breastfeeding journey. That's the optimal goal. So we want to make sure that everyone's coordinating with each other, and the lactation consultants that I work with also do very thorough evaluations and exams, and we'll email or talk back and forth about what's going on, and so that we know if anything else is maybe needed.
Yeah. So what should parents look for in pediatric chiropractors who can who value the collaboration and are gonna refer them to the right people? So what questions should they ask, and how should they find the right person for their child?
So I think that for chiropractic, the best place to go is the ICPA. It's icpaforkids.org or .com. And you can type in your zip code and you can find a pediatric chiropractor. So on there, you will see different initials, whether if they don't have any initials, they're not certified. So you can be a member of the ICPA, but you want to find a pediatric certified chiropractor, or you could just call the office of the chiropractor and say, how many children do you see in a week?
Yeah.
And that will give you so that's probably the best feedback. Or how many infants does the doctor see? How many infants with or tethered ties does the chiropractor see? And then with the other providers, not all lactation consultants are specializing in tethered oral tissues as well. So the parents want to ask specifically if they are well trained in ties.
Yeah. So what would be a piece of advice you would give parents or guardians whose infants or children are struggling with oral ties or feeding issues?
So the biggest piece of advice that I would give is, and my biggest concern is, if the infant is a mouth breather. Because if they're a mouth breather, they're not getting quality sleep because they should be breathing through the nose. And we know that later on, maybe it's an airway issue, they're gonna need to meet with other providers, like Dr. Zaghi, for example, in the future. If they're not breathing correctly and they're sleeping with their mouth open, and that continues, when they get to school age, it's not going to be noted before then until higher learning comes in and there's more demand on that child's brain. They are likely to be diagnosed with attention deficit because of the lack of sleep. When more demand is placed onto their brains, they can't handle it because they're tired. And then you get the teacher saying, oh, little Johnny, he's not paying attention in school, or he's not interested, or he's looking out the window daydreaming. And so that could be a misdiagnosis, because it could be due to the tethered ties and not due to anything else. Other people's concerns are speech. That's a big concern I hear from a lot of parents. The tongue is not going to create any issue with speech unless the tie is a class 1 or 2. Very unlikely class, beyond that, in my opinion. But it will affect eating and feeding as well. So we see a lot of children and teenagers who only like to eat soft foods, chicken nuggets, pizza, pasta. And we used to think, well, that's just kids.
Yeah.
But now my thinking goes, because children with ties don't like chewing crunchy foods or eating steak, anything that takes a lot, because they can't chew and make a bolus properly with their tongue. So they choose those foods because it's easier and more convenient, just innately.
Oral exercises, tongue, and breathing.
All right, so oral exercises are super important in the before phase and healing phase with infants. In the beginning, before they have a release, we want the infant to get used to having our fingers in their mouth, and we want to stretch all the tissues and make them nice and relaxed so that the dentist, especially with a laser, can get a nice deep release. They get a better release, less chance of reattachment. And then in an older child, they're going to see a myofunctional therapist as well, because the myofunctional therapist is going to work with them as they, probably the 3-year-old and up, because they can understand instructions and they can do their own therapy with different tools, etc. And that would be a myofunctional therapist. But with the infant, we have to do the oral exercises for them. Then post release, we need to do more therapy. So whether it is the parents or the chiropractor or the physical therapist, whoever's working with that child is going to work with the oral tissues and give homework to the parents as well to do functional exercises so that we get a good reorganization of that tongue so it functions fully and normally from that point on. Really important, when we have an infant, they can't tell us that if they're in pain. They can't talk to us and tell us what's going on, so it's all guesswork for parents and us. So we're dealing with, in the infant, as chiropractors, the autonomic nervous system and creating balance within that system. So the autonomic nervous system consists of 2 sides, the sympathetic side and the parasympathetic side. Okay, sympathetic is fight or flight. Parasympathetic, rest, relax, digest. When an infant has tethered oral ties, they're frustrated because what should happen normally, they should be able to latch onto that breast, they should be able to take in nourishment, and it should go without having to think. But when they can't do it, they're pulling on and off the breast and moving all around, and they're struggling, and they get frustrated, and mom gets frustrated. And then it's a huge struggle. Where do you think that lands the infant on that platform? Do you think they're in rest, relax, digest, or fight or flight?
Yeah.
Okay. So when they're in fight or flight, that creates the tension in the body and the struggle and more crying. So we may see colicky babies, we may see babies with constipation, reflux. All of those things can occur when the system is under stress. And the most important thing is to recreate that balance. It's called adaptation. That when an infant is born, they should be able to adapt to any environment that they're in and create that homeostasis that we're looking for, to know when their body is able to relax and know when an actual threat is coming at them. And so the nervous system is the system that controls and coordinates that. So if we have interference anywhere within the nervous system, and in babies it's usually way up at the top or way down at the bottom at the tailbone, if there's any interference within that system, it is going to contribute and put that baby into more sympathetic dominance rather than stress. Okay, and the fascia is related to that, like the nervous system is essentially in control of all of that. So if you leave that piece out, you can massage, you can do myofascial release, you can do all of that, you can do oral exercises. But if there's, like the jaw, for example, the TMJ, if it's subluxated, you can massage it all day long and you're not going to correct the problem. So I guess chiropractic is the source, the basis of the correction. So everything pieces together and needs to be done in conjunction with one another to get a resolution, essentially, so it doesn't come back. So breathing is a function of the autonomic nervous system. We don't have to think about breathing. It happens naturally. We're not sitting here going, breathe in, breathe out, breathe in, breathe out, right? That's an autonomic or automatic function of the body. And when we're looking at the nervous system, we're connecting our suck, swallow, breathe, our breath, and the fascial system, right? It's all coordinated and controlled by the nervous system. If we were to just work on the fascia, or just work on massaging the jaw, or just doing exercises for oral function, and there was still pressure on the nervous system, those issues are not going to resolve. They're going to remain there as long as there's pressure on the nervous system. So with a tie, only if there's mouth breathing, oftentimes infants, children, adults with ties will sleep with their mouth open. In an adult, it's going to create, maybe classified as sleep apnea. There may be snoring involved, so the partner's not getting sleep either. But with that in mind, when you're mouth breathing at night, you're not getting quality sleep. You're not getting your full, deep REM sleep, so that when you wake up in the morning, you're not fresh. Your brain is tired. And so what does that look like in a child when they get to school is that they are already tired. There's a new lesson being taught in chemistry and they're fried. So they can't take it in. You think if you look at the brain and you think the brain is filling up as a cup of water and it's right here, and then you were trying to give you more information and it just runs over. And what happens is the child will just deflect, sometimes back down into primitive brain even, and they're just like going la 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 la, thinking about the birds that are tweeting outside or what they're going to do after school. And the teacher takes this as a child who is not intelligent or not attentive. Maybe they need to go see have a neuropsych eval for ADD or ADHD because they're not, but it's really not that. It's that they're not getting quality sleep, and they haven't gotten quality sleep for years, and they're unable to organize themselves to take in that higher learning.
Our next three words are sleep, breathing, and nervous system.
All right, so sleep, as we know, is really important, that we get proper sleep to function properly during the day. And oftentimes people with ties sleep with their mouth open. Sleeping with their mouth open, it's going to cause apnea type issues, and they're not going to get proper sleep. So during the day, especially with children, many children who have ties that aren't released by the time they get to become school age, they're going to have difficulties with focus in school, and they may have a misdiagnosis of ADHD or ADD because they can't pay attention.
Dr. Slak, could you talk a little bit about kind of going back to the idea of like chiropractic versus craniosacral and like when would you use one or the other, and why, I guess?
So I think that with infants, especially, both are necessary in the process of ties pre and post care, because we need to make sure that the fascia heals appropriately and there's no strain. And then we need the chiropractic care to keep the pressure off the nervous system so that we get full functionality. The goal is function. So if an infant, for example, has a tongue tie but they have full function, it may not be a necessary thing to release that tie at that point in time. Also, if an infant has a tie and they go to see a dentist first and they don't have any tension in their body, there's no compensatory strains, there's no tensions, that is a time where the dentist can say, okay, we can go ahead and release this. We don't need to send you for any other care. But both are essential. And oftentimes parents will have to go seek out two providers. And one benefit of our office is that I do both together, so it saves the parents a visit somewhere else.
We do breathing. We did myo. I mean, we don't need to do myo as much,
Yeah.
but
Well,
chiropractic.
on the terminology of myofunctional therapists, so there are a lot of different providers. There's physical therapists, there's occupational therapists, there's myofunctional therapists. And if you talk to myofunctional therapy, they will tell you that that type of therapy is really best for children who are a minimum of age 3 and up, because that type of therapy is where you need to be able to follow instructions and you need to be able to do your own exercises. And an infant can't do that. So in infancy, we need to do the stretches for the infant. We need to get in there and do the stretching of the floor of the mouth and all of that for them, because they are unable to do the exercises. So that's the difference. So typically, myofunctional therapy is not really valid therapy for an infant. And OT, there are pediatric OTs. They're far and few between. I only know one of them in this area, and she's very good. And so she's a pediatric infant OT. What they do, I can't really speak to 100%. You're going to be speaking to one, and she'll be able to fill you in to her role. And then a lot of PTs are learning craniosacral therapy or other therapies to work with infants too. Again, any therapist or anyone that you go to see, you need to find out their expertise, what their abilities are. If they see adults all week long and they see one infant once in a while, that's not the provider that I would choose. Because there's plenty who focus on just infants.